Hey everybody, welcome to the Monday Afternoon Journal Club. Ed Bowder and Dan Schwester here from the Overrun. Danny, today we are going to talk about traumatic injuries because there is a study that came out of Wisconsin. This is Blank and DeMoya. They talked about traumatic hemothorax and pneumothorax and what you need to know. So we wanted to go over this today. This is from July of this year from the Journal of Trauma and Acute Care Surgery, where this is just a, what's that?
Piping hot.
Piping hot stuff. This is just a really good review that Dr. Blank wrote that I thought was important to kind of get out here. 25% of traumas involve thoracic trauma. About a third are going to present with pneumothorax, hemothorax, or a combination of the two. These patients obviously need tube drainage. They need to be decompressed. And usually they require a chest tube and surgical intervention. So it goes into here about like the proper ways to get in there. It's recommended for hemothorax larger than 300 mLs. It should be drained. We don't have access to that type of information out in the field. But I wanted to look at this because the 25% number really kind of stuck out to me. So a third of the 25%, so 11% of all traumas are going to involve hemothoraces, pneumothoraces. That's quick math. But just, it's something that I think is important because I don't know that we address pneumothoraces and hemothoraces enough.
No, we don't. One reason I think is because it's really hard without an ultrasound to adequately diagnose that you've got a hemo-pneumo. We're usually doing it on, on the mechanism of injury and the complaint of pain and some of the other stuff,
the
maybe
exam,
some
breath sounds, things like that.
Yeah, but it's all a clinical diagnosis because if you don't have an ultrasound, you're not going to see it. So we're kind of guessing out in the field when we get there. We know that needle thoracostomy is the answer for the vast majority of us out there. There are some agencies that are now doing finger thoracostomies. I've read both sides. I tend to think the finger is a better way to do it. It's something that hasn't been adopted at a nationwide level or the majority of programs, but it's important to recognize that 25%, 1 in 4 of your trauma patients are going to have some kind of thoracic injury. That can be the guy who falls off the motorcycle. That can be the guy who falls down the stairs. It doesn't matter. What we need to do is you need to do a full thorough exam. You need to listen to breath sounds. You need to use the tools we have to adequately kind of guess that it's there. And if they're showing signs, I'm of the mind that if you think that they need that needle decompression, go ahead and do it. I don't think you really lose a lot from doing it. Yes, they're going to buy a chest tube in the trauma bay. However, you might save their life. And for the most part, it's pretty much a benign procedure.
Yeah. And I think, any procedure is going to come with a certain amount of risks and all of that. But what I think is important to note here, and again, before we get putting ultrasound out onto the units, obviously, this is something that is going to sort of solve this problem, right? Whether or not someone has a pneumothorax or hemothorax, when you can see free fluid actually like in the pleural cavity, obviously that's something that's easy. About 10% of small pneumothoraces are missed, which I think on the EMS side, that's something that we're going to miss all the time. And
that makes sense.
That's not right. And that's more of a function of, the ambulance is loud. It's hard to hear in the back and you might miss a small pneumothorax.
Yeah. And don't forget, Ed, you're going those types of pneumothoraces don't get drained. They get watched.
Right.
They don't get a chest tube. They don't get a pigtail. They generally get watched unless it's over a certain volume.
Yeah. And I think another thing that's important to mention, knowing that this data exists, is it's kind of a way to reevaluate our trauma protocols as well, where if I'm an administrator and I'm reading through a chart and I have a hospital come back and say, hey, listen, this patient had a pneumothorax that got missed, knowing that, 10% might get missed anyway, it might redirect how I'm actually coaching my staff as well. So, coming into this, you have your traumatic patient, right? You have these injuries, you have whatever sequelae associated with it. Listen to their lung sounds, make sure you get a good thorough assessment there. Check for, symmetrical or paradoxical chest wall movement. This is another kind of data set that just kind of explains, do your assessment as well as you can, be thorough, find out what's wrong with these patients. This paper doesn't really go into too much depth about outcomes and all of that. And that's not what we're doing here today. But it's an important note where I think we look at, all right, this patient is a thoracic trauma patient. They might be at high risk for a pneumo or a hemo. or,
I
this is a
love that.
penetrating injury. This is at high risk for it.
Love it.
All of your trauma patients, right? Are they a fall victim? Are they, what happened to them that you
Mhm.
missed? And also, let's keep in mind that a lot of patients are poor historians, where they might not give you what actually happened, or
Right.
something happened that they didn't think about, right? You'll have
Yeah,
someone
100%.
who, and also, like, you have someone who has like Marfan's or a collagen deficiency, where you'll get people who will develop spontaneous pneumothoraces just from coughing. So
Yes.
when we talk about doing your thorough assessment, making sure you get everything done, this is exactly what we're talking about. So kind of a quick hit this week, where we're
It's a
talking
good
about,
review.
yeah, and 25% of your traumas are going to have a pneumothorax or hemothorax. Listen to those breath sounds.
Be
Make
aware
sure
of
we
it.
get these assessments done in these people. Be aware of what's going on with them. Get them to the proper facility. For the Monday Afternoon Journal Club, Ed Bowder and Dan Schwester. Subscribe down below. Check out all of our stuff on overrunems.com and over on EMS1. And we will talk to you next time.
Take care.